I'm going to narrow it down a little further because autism spectrum disorder is just so little known, so I'm not going to talk about it. So I will keep to the attention deficit disorders. These are my disclosures, so there's many. This is what I'm going to talk about. Just say a few words about the model about comorbidity, and then taking a few approaches, looking at the epidemiology, the genetics, and the neurobiology, and from there, thinking about what the treatment could be of this comorbid condition. So if you think about the model in general of comorbid disorders, then, and you can think that substance use disorder can cause ADHD. Now, ADHD starts most of the time at a young age, so this is actually not very likely the case. You might also think that patients with ADHD might try to use stimulants to treat their ADHD symptoms or cannabis to sleep, and that they, in that way, develop a substance use disorder. It's also very well possible, and I will show you later that this is probably one of the ways that it goes, is that they share genetic and environmental predispositions, and that this is causing their comorbid occurrence. And finally, it might be that the treatment of ADHD and substance use disorders are actually negatively influenced by the other disorders, and by that there will be an increase in the comorbidity. So this is the model in general. Now, if you go to the literature, this is more how it looks like, and I'm going to change this model slightly later on. But what you see here is, if you look here, these are all the biological risk factors for ADHD. And according to this model, these risk factors and these behaviors lead to academic failure in ADHD patients, to social difficulties and conduct problems, and these in turn will lead to substance use disorders. Now that might be slightly different if you listen to the rest of the talk. For me, from now on, this is probably the model that I'm going to use in the rest of the talk, showing that genes and environmental factors may cause ADHD, and maybe they'll cause substance use disorder. But it's not completely clear whether this is a direct relationship between ADHD and substance use disorder. This might also be that genes cause ADHD, and only in these people that develop also a conduct disorder and maybe an antisocial personality disorder, they develop substance use disorders. So I'll say a few words on that later on. So what kind of approaches can we have to this comorbidity? So I'll mention three: an epidemiological approach, a genetic approach, and a neurobiological approach. If you look at the epidemiology, I think there's quite some data around now. This is a meta-analysis that we performed some years ago, including 29 studies, showing an overall prevalence of ADHD, adult ADHD, in substance use disorder patients of about 23%. Now, I have to say, this is 23%, but it was quite a big range, anywhere from 10 to 50%. And so we recently did a study in Europe, and actually Europe and the United States, to look at reasons for this huge variability, using a method that we, in all the different countries, we used at least the same assessment instrument and the same recruitment strategy. So what did we find there? Basically, we found that the overall prevalence is indeed somewhere like 15%. But if you look what the differences are, and here you see country difference, I can say that DSM-4 and DSM-5 didn't make a big change, although there were worries about it, but they didn't make a big change. But you see big changes in between countries. And now it had many reasons, because in some countries we saw only drug addicts, in other countries mainly alcohol addicts. In some countries it was basically in or out patients. And of course, certain countries, ADHD patients go to mental health service, and in other countries they go to substance use disorder clinics. And so this explains quite a lot of variability, and actually we're afraid of giving an actual number because it's so much dependent on the setting, the primary substance of abuse, the country, and as we heard before from Gabriele Fischer, the gender. So it is anywhere between 5 and 30%, but in all cases it's very substantial. Now, this is people who come to treatment, and there might be a strong selection or Bergson bias. And so if you look at the literature in the general population, you see something very similar. This is a study, some 8 years old by now, looking at the cross-sectional general population samples. And so what you find is that lifetime prevalence of adult ADHD was 3.4%, ranging from 2 to 7%. But in people, not patients, general population, people with a substance use disorder in the general population, the prevalence of ADHD was 12.5%, which means that it has an odds ratio of about 4. And most of these cases, ADHD was first followed by substance use disorder, only very rarely the other way around. It also shows that treatment rates were, at that time at least, very different, with almost no treatment for adult ADHD in Europe and outside of the United States. Now, you may say this is just cross-sectional. How is the relationship between ADHD and substance use in longitudinal study, in prospective studies? Here, these are two large meta-analyses, and they show actually if, as a child, you have ADHD, the probability that you develop a substance use disorder is 1.4 to 3.5 times higher than in the general population. That doesn't take into account the role of conduct disorder, and I showed you in the model that that might be an interesting thing. Some people have said it's actually not ADHD that is predicting that's causing substance use disorder, but it's the conduct disorder people. So the question is this relationship between ADHD a causal one, or is it indirect through conduct disorders or antisocial personality disorder? And this is just quite an old study already, 6 years old, showing that at the age of 40, they looked at the relationship between alcohol dependence and ADHD. And what you can see is if you have neither ADHD or CD, conduct disorder, the rate is quite low. If you only have ADHD, it's quite an increase with 1.6. Only CD, you see, conduct disorder has a much stronger effect. But you see, if you have CD plus ADHD, again it increases. So it seems that ADHD is an independent risk factor of becoming addicted, although conduct disorder is very important. For the sake of time, I'm going to stop this one. You may also think if it's a causal relationship, if ADHD is causing substance use disorder, if you actually treat ADHD before they can develop ADHD, substance use disorder, maybe that is also an indication of causality. So there have been studies looking at young kids with ADHD, whether, for example, prescription of stimulants might actually predict or the non-occurrence of substance use disorder. So this was one of the first studies by the group of Rachel Klein. Actually, they started off with 176 children. They picked them up at the age of 6 to 12, followed them up for 12 years. And you see what happens at the age of around 20, 22, 45% of these children with ADHD have developed a substance use disorder, both alcohol use disorders and drug use disorders. A very dramatic situation, which I think we have to realize. And then they looked, if it's 50% actually gets addicted, there's other 50% that don't get addicted. So are there predictors? And they looked at many predictors, I think about 30. None of them actually predicted whether they would become addicted, except for one. And that's the patients, the young patients that started at an early age with stimulant treatment, with methylphenidate treatment in most cases, they had a smaller risk of becoming addicted. Now, meanwhile, we have many more studies, and this is a recent meta-analysis showing the data of 15 longitudinal studies, including 2,500 patients. And the conclusion of that meta-analysis that stimulant treatment of young people with ADHD has neither a negative effect nor a positive effect. There's no effect, which I think, sorry to say, it's quite a ridiculous conclusion, because if you see these forest plots, it just goes everywhere. There are studies where they find a positive effect, there are studies where they find a negative effect. And so what you want to know is what kind of studies do find a positive or a negative effect. And so if you then start to look, they find two predictors. And it's the percentage of patients that get stimulant treatment and the time since the diagnosis. And if you read a little bit more, then you see they don't take into account the severity. So you might think that if the most severe patients actually get stimulant treatment at the youngest age, then even a result of no effect is actually a very positive outcome. So if you start to look at that, I think these data actually indicate that it's very likely that early treatment of children with ADHD is protective of becoming addicted. This is a study done in the Netherlands. It's probably one of the most recent ones. It was published in 2013, British Journal of Psychiatry. The good thing about this study is they took into account actually the ADHD severity and the presence of a conduct disorder. And what this study clearly shows that actually if you have ADHD, this is the normal controls in the development of substance use disorders. If you have ADHD and you're not treated with stimulants, this is the risk that you develop an addiction. Whereas if you are treated with stimulants at a young age, you see it almost normalizes the risk of becoming an addict. So again, it shows very clear that early intervention, and this is with stimulants, and we have heard yesterday very good stories about the good behavior game or the family intervention. Similar results could be maybe actually achieved with treating ADHD children to actually prevent the development of substance use disorders. Now, the second approach, genetics. I always use this kind of a scheme, but is there any indication that there is a shared genetic vulnerability to these disorders? This is a wonderful study from Ken Kendler already from 2003, actually showing the genetic and the environmental contribution to common mental disorders. And here you see internalizing disorders, depression, anxiety, phobia, and here you see the externalizing disorders, alcohol dependence, drug dependence, adult social and social behavior and conduct disorders. What this very clearly shows is there is probably most of the genetic contribution is a more general genetic contribution. It's impulsivity. And actually what you see here is that there is no ADHD there. So you can speculate whether ADHD is also there, but there's no data at that time. We recently did a study and we showed that the heritability of ADHD was 38%, of alcohol use is 50%. So there was a phenotypic correlation of 0.30, and that correlation was almost exclusively explained by genetic variants. In short, comorbidity is strongly genetically determined. I'm going to skip probably the neurobiology because I'm not going to have time, but it is important that ADHD and drug use disorders share a lot of their neurobiology. This is just a picture that I use. This is the genetics. This is the endophenotype, and you see it's a hyperactivity reward system and the deficient control system, which is very clearly also present if you see the ADHD characteristics. And this is just a lot of pictures that show that ADHD and substance use disorder have very similar problems. Here you probably see no activation in error monitoring. Here in the controls you see activation of the anterior cingulate cortex. In smokers you don't see it, and here in pathological gamblers there's nothing. Similar tasks in ADHD patients show the same thing. This is normal controls and this is adult ADHD patient. You see there's no activation on the anterior cingulate cortex. Similar in terms of the reward deficiency. This is data from Nora Volkov showing that low dopamine dopamine receptors in the ventral striatum in abstinent drug users. Very similar data with regard to ADHD. So I think this picture has to be changed. They just share a lot of the neurobiology, and there's a direct pathway from the neurobiology to the comorbidity. So a few words about treatment. A lot of treatment studies have been done, and this is just to give an overview till 2010. Actually, if you start to look at the RCTs, there are much less of them. And so here you see the RCTs, and if you look at them, you see there's, except for a few, actually there is none that has anything on substance use disorder. There's very little there. And so the question is, what's going on? So we're in a situation that we have very high prevalence of ADHD and substance use disorder. We have no effective treatments until recently. Stimulant treatment in these patients didn't have any positive effect on the ADHD symptoms and not on the substance use. So what was the reason for that? Was there any reason? So I think we know something about the neurobiology there. We recently did a study looking at the occupation of the dopamine transporters by methylphenidate, and that's the mechanism of action. And then we saw in ADHD patients, compared to cocaine plus ADHD patients, the occupancy in cocaine-dependent patients with ADHD was just much lower, which indicates that maybe you have to give higher dosages of methylphenidate. This study of Norfolkov shows that actually if you give methylphenidate to cocaine addicts compared to normal controls, you see a lower level of dopamine release. So both indication that we might have to give the higher doses. And because Adam Bazaka gave already the results, this is what is done now. Go to higher dosages because the biology is requiring it. And so I'm not going into the data explicitly, but here you see the effects of up to 180 milligrams of methylphenidate in these this amphetamine addicts. You see wonderful effects on ADHD with a number needed to treat of 2, which is a wonderful effect actually. And here you see the effects on amphetamine use, but actually it's even nicer. You see also a reduction of other drug use. So it's not only substitution, you see actually you do actively something about the general use of substances. It's very safe. This is another study that Adam showed, showing the effects of ADHD patients and cocaine dependent using what she calls robust doses of dexamphetamine, 60 and 80 milligram. The best effects on drug use was actually with the 80 milligram. Numbers needed to treat 2.5, very strong. And on ADHD symptoms, actually the 60 milligram was the best, but you see numbers needed to treat of 3. Very strong effects. So altogether, I think the conclusion should be that these disorders are very highly comorbid. They are dependent, these prevalence, on all kinds of factors. But ADHD seems to be a partly independent risk factor for the development of addiction, probably mainly because they're strong genetic overlap and thus they're very strong neurobiological overlap. And the treatment of ADHD in patients with substance use disorder and actually the substance use disorder itself is unresolved. But I think we have strong indications that integrated CBT and probably the best so far, high doses of stimulants are probably the most promising treatment. Thank you very much.